So an expert group of dementia specialists, as we did with aducanumab, put together a guidance, appropriate use recommendations for clinicians who are considering using lecanemab in the clinic. We don't take a position about whether or not it should be used, or we don't debate the merits of the treatment. We talk about, if you're going to use it, how to use it safely. And the key here is really to select the appropriate patient for treatment and to know how to monitor the treatment to make sure it's safe. So these are new treatments that have some potential benefits for patients, but they also have significant risks and they need to be managed carefully. So basically, we built on the phase 3 data, the protocol, and the data in terms of guiding management. And it's closely aligned with the FDA, but it adds some extra safety features on top of what the FDA prescribing information currently includes. And that may change because lecanemab received accelerated approval from FDA, but it's also under consideration for a traditional approval, which could come in July. And that could also include an updating of the prescribing information. So the key takeaways here are that this drug is approved for people with early Alzheimer's, so mild cognitive impairment or mild dementia. The mini mental state range is 22 to 30. The main request where clinicians need to be careful will come from patients who are more impaired than that. There's no evidence that there's benefit for those patients. It requires confirmation with amyloid testing, either with PET or CSF. I think blood tests could be used as well to help determine who should have PET or CSF. So that's a new feature, which we mention in the appropriate use recommendations as a consideration. And then it's very important to make sure they have no exclusions. So a close look at a recent MRI scan to make sure there's no stroke, hemorrhage, severe white matter disease, multiple infarcts, microhemorrhages, evidence of cerebral amyloid angiopathy, et cetera, et cetera. That's really critical because those patients are going to be at higher risk of a more serious outcome. We've taken a position that patients on anti-coagulants not go on this medicine, not be considered at this time. The data is insufficient to support that, and there's an increased risk for hemorrhage, of a major hemorrhage with anticoagulation and lecanemab. So that's important. That's mentioned by the FDA, but it's not an exclusion, and we're recommending that right now those patients be excluded from treatment. And then we give specific recommendations on using MRI and how to monitor and manage ARIA. So that's really important, that many clinicians will not be familiar with ARIA or its management. And so if they want to provide this treatment for patients, they need to train themselves and work with a radiologist that's also familiar with it so they can manage it safely. And that's going to require testing for the ApoE gene. That's something new in clinical practice. It can be done. We've been doing it for years, but it's something new in general neurologic or dementia care, Alzheimer's care. And it can be done either with a cheek swab or with a blood test. There needs to be coverage for that, but we recommend that that be done in all patients being considered for lecanemab, because patients and families need to know what their risk is for ARIA and more serious ARIA. And also the clinician needs to know that in terms of managing the ARIA. So they're going to be more vigilant in patients who carry 2 copies of E4 because they're at risk, higher risk of ARIA and more serious ARIA. It's very important with ARIA to catch it early to avoid turning a mild and manageable side effect into a serious one. And there have been fatalities reported with lecanemab related to ARIA. The key here really is a careful risk-benefit discussion with the patient and the family. If you have an appropriate patient, so they meet the criteria, the mini-mental, the cognitive level of a cognitive impairment, they don't have any exclusions on MRI scan, they have MCI or mild dementia, they have amyloid confirmation, then it's important to know their ApoE status and then have a discussion with the patient and the family. Okay, what's the potential benefit? The potential benefit is mild. It's not a major benefit. And what the risks are. And then the family can weigh and the patient can weigh those and decide whether or not it's right for them.